Welcome everyone. I'm Vidya Krishnan. I'm a journalist and author of The Phantom Plague. Joining me today in conversation are Sarah Fortune, Chairman of the Department of Immunology, Chair of the Department of Immunology and Infectious Diseases at the Chan School of Public Health, Carole Mitnick, Professor of Global Health and Social Medicine at the Blavatnik Institute at Harvard Medical School, and Nick Menzies, Associate Professor of Global Health at the Chan School of Public Health. We are here today because of my book, and I want to start us off with why I, who's not a student of medicine, felt compelled to write about tuberculosis. And it's because I was living in Bombay, which is the hottest of hotspots, and I was watching people die from a disease I was told has a medicine, and we had all the tools. And it started me down this rabbit hole where I had to kind of make sense of why is it that Indian patients today don't have access to the latest therapy, despite India being the pharmacy of the world. And I tell the story of this teenager who had to take the Indian government to court to access this new drug, bedaquiline. And in that process, she died while trying to do that, trying to make sure that patients behind her did not have to fight the same fight. And all of that brings me here. In the process of writing the book, I realized that the same story that Shreya, this teenage kid, was living through was also unfolding in South Africa, where Fumeza, another patient who was dealing with the same disease. And this story keeps on repeating itself over and over again in every part of the world. So I want to start us by kind of getting us some context of, could you place us in this current moment in time with respect to the tuberculosis burden we are looking to tackle? And, could you tell us how do we go forward from where we are right now? Professor Fortune.
Okay, well, I will start with where we are, because how we go forward is a more complicated question. But where we are is actually surprising to many people. So TB is the leading infectious cause of death globally. There are about 11 million cases of TB every year around the world, and about 1.5 million deaths. And so to put that in context, in about 2020, globally, there were maybe 1.5 million, a little more than 1.5 million COVID deaths. Mm-hmm. And so that's that same order of magnitude of mortality that's happening every year around the world in a disease that we and many other people around the world kind of take for granted has been erased. And so that's where we are at this moment.
Yeah, I guess, Sarah, if I can, so to expand upon that. So I think, as you've said, we have a huge current burden of TB. If we look over the past 10 to 20 years, we have seen some slow progress, but progress. But I think right now we're at a point where if we look 5, 10 years from now, we could either potentially be in a much better spot with TB, like there's new scientific findings, there's new interventions we might deploy. But at the same time, I guess this is sort of the backdrop to our conversation, there are these sort of large changes in funding for TB, which could mean that in 5 to 10 years, we could be a lot worse. And so as everyone knows, the US has withdrawn funding to USAID and potentially could withdraw funding to other major funders like the Global Fund, which supports a lot of sort of TB control abroad. We saw during COVID-19 that if there is a small reduction in the amount of care people can get for TB, TB can come back quite quickly. And so those long, slow reductions we've seen can all be lost very, very quickly.
Yeah. Carole, if I could bring you in, why is it so difficult to treat TB?
Yeah, I think it's an equally shocking piece of information to people than that TB is still alive, and that standard TB treatment, run-of-the-mill TB, takes a minimum of 4 months to treat. It is a wily bug that is capable of evading many different mechanisms of actions of drugs. It requires multi-drug treatment, so that the 4-month regimen that I mentioned requires 4 drugs, and there are 4 drugs for 2 months, and then 2 drugs for 2 months. It's a long time to treat. The regimen's highly effective, and the 6-month regimen that we've used for many years is highly effective. And there are side effects that we tend to discount, and those side effects are one of the things that also make it challenging. The length of care and the fact that people who are affected by TB are disproportionately impoverished people living in settings of impoverishment. And so taking TB treatment may not be their first priority. All of our tools in TB are quite old. For a long time, we're relying on a diagnostic that goes all the way back to the 19th century. And our vaccine is from the early 20th century, and it really does very little other than preventing disseminated disease or serious disease in young children. And so there have been some improvements in treatment. There's a newer diagnostic, but we're working with a challenging bug and with really limited tools.
Yeah, if I could, I mean, that cues me up for the next question. We are dealing with old tools, and we seem to have 19th century tools for a 21st century battle. And I was wondering what makes you excited when you look at innovations in TB right now?
Yeah, so this has always been what we said. We have 19th century tools for a 21st century battle. And so I've worked in TB for 25 years.
Since the last century.
Yeah, since the last century. And this is an unbelievable moment. I mean, this is just the moment when all of a sudden it seems like the scientific promise of the work over the last several decades is really being realized. So we have new drugs that have transformed not just the treatment of drug-resistant TB. So it used to be drug-resistant TB was like a year of a lot of these super toxic, injectable, turned you blue, made you psychotic kind of drugs, and it is just transformed. And we had this very dogmatic view on how TB was spread, and all of a sudden, and we kept trying to intervene in the points where we thought TB was spread, and over the last 3 years, we've all of a sudden recognized actually TB is spreading in totally different ways than we ever anticipated, and therefore we have totally new ways to intervene. And so in this moment when the global political situation makes the future of TB very uncertain, as a basic scientist, it's a super exciting time to work in TB because you just see the possibility of what might happen.
Yeah, Nick, what does the math say about how hopeful can we be that the innovations that we are looking at will actually translate and trickle down to the places where we need them the most?
Yeah, sure. And I guess just to introduce that, so I'm a mathematical modeler, which means that part of my job is trying to understand what these new technologies, what they might actually mean. And so I see it as sort of a continuum. So as Sarah mentioned, we have new diagnostic tests. They are available right now. They are in no way perfect, but they're so much better than what we had before. Okay, and so that's of something we have right now, and we just need to make sure people have access to it, I think, following the point that you said. Then we have new stuff under development, and so what I think someone mentioned that our current vaccine is very, very old, and it doesn't really help us address transmission. We may, in 5 to 10 years, have maybe one, maybe multiple new TB vaccines. I think that's one of the big reasons for hope. TB prevention is really hard, like even to prevent TB. These days you need to give people, at least 1 month, but generally sort of 3 to 6 months of drugs just to prevent TB. If we have a vaccine, we can make that so much more easy. So that's coming. But also this information on how TB is sort of transmitted, that was mentioned that we're now realizing that about 50% of the people who have TB that could be transmitting TB to others, they don't know they have it. And so that's not an intervention yet, but that's the information we need to build better interventions to see how we can address asymptomatic TB.
Yeah. Do you mean like people with latent tuberculosis who don't know they have. Is that what you were referring to when?
Well, certainly latent TB is an issue. About, I think, 1/3 to a quarter of the global population are infected with TB. Most of them will live their lives and have no effects, but some will progress to TB. But no, I'm thinking about people who have active TB disease, and so they are, when they breathe out, they could be breathing out TB. They might have some symptoms, but they're not the symptoms that are leading them to seek healthcare. Right. So they're in their homes. They might be transmitting to their family. They might be transmitting to their social contacts. We now know that that is a really important thing to address. We didn't know that 10 years ago. So 10 years ago, we were focusing on treating the people who are sick. Now we know the full scale of the problem.
We would have called those people latent. So that's the problem.
Yeah.
We would have called those people latent, and actually they were out there transmitting TB.
Oh, wow.
Yeah.
Wow. Is there like a new word for
subclinical TB is the term that we're using for people who don't have symptoms but who do have active disease. And there's also a better appreciation now that it's not really dichotomous between being infected and having active disease, that there's probably a spectrum, and people's immune systems are able to kind of return to the infected state where there's no risk of transmission, and then maybe there's a weakening moment and they could progress all the way to active disease. Yeah. But we think people go back and forth, and we didn't appreciate that before.
I hear all three of you talk about these innovations and this future where we have tools and vaccines and science marching forward and with all the solution, but we are also in a moment where there is such lack of trust towards science and against scientists. And as someone who documents, I write about science from the global south, and I will confess that I was not, maybe I'm naive, I was just not prepared for the kind of anti-vaxxer movements we saw during the pandemic around the world. And I personally thought when the vaccine was announced, I was like, this is like moon landing, but also more impressive because it was on the clock, people were dying.
Yeah.
And it was met with such vilification of science. And I was wondering, I would like for all three of you to say, how do you switch this narrative and bring trust, faith back into science? Perhaps you could start from that end of the table.
Sure, and hopefully this is not too controversial, but for me it is to respect those concerns. And so, so we know so much about TB, and we think that it's entirely clear what is right and what is wrong and what is good for people. As I mentioned, a lot of the new interventions we might need might be interventions that are given to people who do not feel sick.
Right.
And so for that individual, we need to be able to, sort of seriously demonstrate that what we are thinking they should take, it's not, to protect the community, it is also good for them.
Yeah, yeah. And Carole, what do you?
Yeah, I would build on what Nick said, and I guess come back to the comment I made earlier about the adverse events that come with treatment. And I think we haven't done a very good job. I didn't, when you asked the question about what's hard in TB, I didn't mention the fact that we have always worked with a limited amount of resources for TB relative, say, to HIV. And some of that, I think, is self-inflicted in that we tend not to think creatively and think about demanding more resources for this disease. But I think the consequence of that is that we have expected people just to tolerate the options they have. And I think engaging more with communities about their needs, about understanding what are the relative advantages of this new 4-month treatment, which we thought people were going to be super excited about because it's a third shorter than the standard 6-month treatment. But apparently nobody wants it because the pill burden is really high, and also the adverse events are more substantial than the 6-month regimen. And so I think engaging with communities who are affected by TB to understand what their priorities are I don't know if that will stop the vilification, but it might blunt it a little. It might blunt the impact a little bit, so that it may help the mistrust side of things. Yeah. Or I prefer distrust, actually.
Mm-hmm. Yeah, mistrust. What do you make of it?
Well, I think that the mistrust or distrust is often coming from outside the community of affected individuals. And so while it's important to engage the community and actually be really serious about safety and adverse events, like in a way that we haven't maybe done as well as we should have previously, I think the sense that the scientists are really people fighting individual on individual quests or on community quests to really improve the world may be an important narrative. I don't know, it's like a little self-serving narrative, so I'm not sure. But it is striking to me the contrast between the public narrative of science and sort of the personal experience of people coming to work every day, excited about making incremental gains or failing to make incremental gains in the fight against a really complicated disease that needs smart people to engage, and honestly, not a well-resourced field. I mean, it's not like we're oncology.
Yeah.
And so these are people who are showing up, working hard in a field where they believe sort of in the moral good. And I would hope that that narrative has some sort of humanizing effect in the conversation.
Yeah, that's so interesting. I read in some history book that when Hannibal he would, like, there were armies throughout history who, as a part of the army, would take writers with them. And I feel like scientists should just, anti-science is so self-perpetuating, whereas science needs an army of people who are like writing love letters to scientists, which is what happened during the moon landing, where there were celebrities, which is so different to, which also brings us to the next. So many, there's so many good people working at a time where there's so much under-resourced field, and we are also now looking at a situation where so many countries are pulling back support for all of these research areas, but also global aid. And I wonder, how do you see it impacting? And again, I'm going to start with Nick and then come this way.
Yeah, well, certainly, I mean, easy to say, but important to say that what is happening right now will have major implications, and it'll have implications right now. We know that interruptions in care can mean that individuals who have diagnosed with TB may not complete treatment. They may develop some resistance to the regimen, which would have otherwise been effective. People who have TB and don't get diagnosed will go on to transmit to their family members. And we, as I said, we saw that during COVID. Like, TB rates, I think, were the highest they have been in the last 20 years last year. And that's all to do with what happened during COVID, the interruptions in care. So we could see the exact same thing happen in some of the highest sort of burden places. And I guess, I mean, sort of taking this question in a slightly different direction, I see this as a partnership, because I can tell you right now, if we see TB come back and come back strong in a lot of global regions, we will see it come back strong in the United States. We'll see it come back strong in France and in the United Kingdom. Like, TB is a disease which connects the world, just because there's such a long sort of latency period for some people between infection and disease. And so it's hard for us to kind of wall off one part of the world or one part of the problem and say, okay, it's bad, but it's only bad there. If we have these sort of funding gaps, as might happen, it's really going to affect things globally.
Before we come to you, I just wanted to put this thing that in India, if you now apply for a US visa, they can ask you for a chest X-ray.
Yeah.
Because of TB, and with the aid going away and funding crisis, how do you see the next few years?
Yeah, I mean, I think it's pretty dire. I think the current estimates of the consequences of the COVID pandemic are that there were roughly 700,000 excess deaths due to TB in the period from 2020 to 2023. And so I think we're looking at something probably even more stark than that, because in most cases during the COVID pandemic, services were shuttered or effectively unavailable for a period of a few months at a time in particular geographic areas. And that may have cycled through multiple times. But if we are talking about an interruption on the order of 2, 3, 5 years, that impact is going to be far greater. And I think, as Sarah was saying, we do have this incredible opportunity with all of these innovations, and missing that window to implement them will be huge. I guess on the flip side, I think opportunities will emerge in the future that scientists will continue to discover, and people will continue to be motivated to work in this space, perhaps more motivated than ever, given what may transpire, and we may have better models for collaboration, better models for providing support for those who need it.
Sarah, do you see the future in that optimistic?
I'm sort of a glass half full kind of person, and so yes, I do. I also am a bacteriologist, so I kind of root for the bacterium like sometimes.
Do you?
Well, you're just like are fascinated with the biology of it. I think that actually I wanted to just touch on this idea that the United States thinks it's going to protect itself by requiring chest X-rays from visitors, which we have done for a long time. Actually, part of the discovery of subclinical TB is sort of the upending of the comfort with which we could approach those sort of blunt assessments of whether people have TB or not, or are transmitting TB or not. So that was sort of old school, like, we'll keep people out. And the reality is that TB's in the United States, and in fact, we've invested a lot in our public health infrastructure. If you have TB here in Boston, a public health nurse goes out to your house and does case finding all around you, and that's how you keep that burden low in the United States. And disassembly of the public health infrastructure here under a different set of priorities will mean that actually TB is going to be here at much higher levels, and in fact is here in higher levels than people think. And so we should not get seduced by the idea that our healthcare system is exceptional.
May I just
Yes,
touch
please.
on that, Vidya? Because I think Sarah's raised a really important point here, that we have had kind of waves of support for the public health system. Longtime TB physician and researcher Lee Reichman referenced the U-shaped curve of concern, and that you get these peaks of TB, and then you get investment that follows, and then the TB rates go down, and investment goes down because people forget that actually the latency can last for generations, and then the same thing, the cycles happen over and over again. Well, we're in one of those periods now where TB rates are going up in the US. We have the worst outbreak that we've seen in decades going on in Kansas right now, and where public health departments can't get the drugs they need for TB here in the US. We're hearing that in Canada, where resources are being cut off for the very kinds of contact tracing and case finding that are required when you have an outbreak. And so I think we're perpetuating our own bad cycle of TB here in the US right now.
Yeah, and Nick, were you going to say something?
Well, certainly we're talking about right now the harms that can happen through reduced funding and reduced sort of effort. But I think what will happen in terms of funding over the next 1 to 5 years are not yet set in stone. So I see this as a moment of great sensitivity. Like with the technological developments, and when I say sensitivity, that is to say our actions could either lead TB to get a lot worse or for us to have a much greater impact. Like the whole point of all this of scientific innovation is that scientific innovation in and of itself does nothing. It puts us in a position to then have a big impact. So if we have better treatments, better diagnostics, a new vaccine, then with I guess, maintenance of this partnership between high-income countries like the US, but also high TB burden settings, which invest an incredible amount in dealing with TB, that if that partnership is maintained, we can leverage all those new innovations and actually can control TB. So this is a moment where, things could get, this is the cup is half full, cup is half empty. Things could go bad, but things could also go really well depending on what we do.
That is optimistic. You were saying you're rooting for the bacteria. I'm the biographer. I feel like I'm a biographer for this bacteria. And one of the things while I was researching it completely as a non-science, as a writer, is how it travels parallelly with capital. How the colonial roots of a huge portion of the book goes into how we structure the economic order also fuels this disease, but all sorts of infectious disease, but TB in particular. So I wanted to ask you, Carole, about the fragility of our global health, but particularly why is TB such a litmus test of the global health system that we've...
Yeah, I mean, you write about it beautifully, Vidya, in your description of how the whole kind of social structure in India, and you focus in on Mumbai, really supports the continued success of that bug. And by bringing in large numbers of people to live in very, very densely populated, poorly ventilated, little sun access, little outdoor space communities, in order to serve a very wealthy population, that's kind of a perfect storm for tuberculosis. And in the case of Mumbai, where there's quite a bit of multi-drug resistant TB circulating, it's a perfect storm to support multi-drug resistant tuberculosis. So I think until and unless we address these larger structures of resource distribution and conditions of living, I think we are unlikely, I'm reverting to more like the glass quarter full, we are unlikely to see additional major gains in TB. So in the US, we saw enormous declines in TB in the middle of the 20th century, and that was true in much of Western Europe as well. And that was before we had antibiotic treatment. It was because living conditions improved, because nutrition improved. And so those things are going to be really essential. And if the ability to ensure good living conditions and good nutrition is fully dependent on the kind of system that we had to date, the kind of system of aid that we had to date, I think it doesn't bode super well for the future. And what we're seeing at this moment in time is just how fragile that system was. I think, in the US, there's been bipartisan support for foreign aid for decades. And so I think to many of us, it was a surprise that there was such a rapid and complete cut of that foreign aid. But it is clearly susceptible to changes that we hadn't quite anticipated, and I think we'll probably have to rethink how to approach that in the future.
Yeah, and this is an important point in terms of, we're thinking about what I would think of the proximal determinants of TB. That is the things really close to the bug which we can affect, like we can prevent it, we can treat it. But all of those treatments and preventions, they sort of sit in this larger sort of social sort of environment. To me as a scientist, I see that almost as a good thing, because that spreads out this causal chain of TB where we can attack it at any point. And so we don't need to do one thing. We don't only need to think about treatments and vaccines and that kind of thing. We can have fantastic people working on that. We can have fantastic people working on just understanding what the bug is doing, and we can have fantastic people working on how we can sort of rethink our social structures that'll lead to everybody living better lives. And all of those can happen, all be working together.
And can I put Nick's comment in perspective?
Of course.
Actually. So the importance of very basic interventions cannot be understated.
Right.
And so there was a trial in India called the rations trial of basically providing food. And the act of providing food to people who are undernourished reduced TB incidence almost as much as the best candidate vaccine in trials right now. So those are really startling numbers because, in fact, India could provide food for its people right now. You know, at some level, it has the ability, and we globally have the ability for transformative action in TB. But I mean, gosh, we'd be feeding people, and wouldn't that be awesome too?
Yeah.
And so, you know, there's enormous scope for action in my glass half full now. The fact that we can't feed people, even though feeding people seems so fundamental, independent of TB, and that we're talking about sort of TB interventions as a reason to feed people, is a sort of disheartening statement on humanity.
Yeah, yeah. I followed the rations trial. I've written about it. And I'm wondering if what you're saying is that food, because I was looking at the data on how many lives were saved just by giving nutritional support. Are we saying just giving nutritional support is as good as having a vaccine?
I think no, technically not, because in fact, probably, okay, there's this little side, you know, babies, we give a vaccine to babies to protect babies against TB meningitis, and that clearly works and is important. I don't think if you fed babies more, you're going to protect them against TB meningitis, and TB meningitis kills a lot of kids. But we could prevent a lot of TB by feeding people, and improve quality of life and outcomes on like the cascade of benefit.
Yeah.
And so I think this sort of "and" statement is maybe a better way to frame that.
Yeah.
Yeah, yeah.
And thinking again, while Nick said preventive therapy, the existing preventive therapy is suboptimal. It's definitely vastly improved now that we have a single month regimen that's every day for a month, or a regimen that's once a week for 12 weeks compared to the 9-month versions. So while that's less than ideal, it also has a very, its impact on preventing TB has been extremely well established. And you could imagine that combining an aggressive preventive therapy intervention together with food would have enormous impacts on those households at risk and on the communities in which these people are living.
Yeah, every time I hear you talk about TB, it gives me hope. And then every time I find myself in a slum in Delhi or Mumbai, I'm like, it's a little, and now how we look at what's happening from the global south, from post-colonial nations, what we see is a complete abdication of responsibility as the United States government changes its policy. And it's also so sudden. And I'm wondering what you, perhaps Sarah, starting with you, think are the essential, like the babies that you don't throw out with the bath water at this point? What are the features that you think are critical to retain within the structure, as flawed as it is in global health? What are your worries about where we are right now?
Well, okay, I'm going to, before I answer what are my worries, I just want to emphasize that there are places in the world that are actually cause for hope as well. So I was in Limpopo in the fall, and bedaquiline, an all-oral regimen for multi-drug resistant TB is being rolled out in the poorest province in South Africa, and there was just enormous excitement that this was reaching people who thought that they were going to be abandoned because they were so poor. And so there are places where that promise is being fulfilled, and obviously many places where it is not. If one had to sort of distill down the core elements of things that you hope would not disappear, drugs, diagnostics, BCG for babies, and I'm not rank ordering here, but HIV care. So antiretrovirals.
Yeah, no, this is critical. Although I must say, if it's okay, I'll take issue with the question because it's conditioning on us accepting that we should, or at least, that the West will invest less. And I think, I don't want to be Pollyanna-ish, but I think the first thing is that's still an open question. And so I think like doing what we can to maintain our side of the partnership. Because again, lots of people are contributing to TB control programs. It's not just the US, it's not just high income countries, but so to maintain that part of the partnership is incredibly important. In terms of what you might keep if you're forced to retain funding, that is really hard. So we're sitting here, and certainly Carole has a lot more experience in how programs work than I do, but also in a lot of these programs, there's incredibly hard-working, intelligent people who they will honestly be the ones to know what they can save if they really need to save money. Like Sarah makes the point about HIV treatment programs. Some of the best gains we've seen in TB control in the last 20 years has been through scaling up and maintaining antiretroviral therapy in Southern and Eastern Africa. Like in those countries, TB was high, but not too bad. But then with the advent of the HIV epidemic, we saw TB exploding in a lot of countries in that region with the scale up of antiretroviral therapy, which can protect people's immune system. We saw TB rates come back down again. So maintaining that contract or that partnership is incredibly important.
Yeah.
And I would add to that, I think to Nick's point of kind of pushing back on the framing a little bit, that we already know, we already have estimates that for every dollar invested in TB control, and that's across the board, whether it's preventive therapy, treatment, diagnostics, the whole package, the return on investment is huge. It's estimated to be about $50 for every dollar invested in TB control. So I think it is incumbent upon us to do a better job of communicating that to those who would threaten that investment, and really I think present this as a comprehensive package that, again, where we saw the biggest initial gains in the US were before there was any antimicrobial treatment for TB. And then that treatment was able to, make a much more profound impact after nutrition had already been improved, after housing had already been improved. And so I think we will want to continue to work on focusing on a broader package. And if we have time, we can talk about what that might look like.
Yes, I wanted to come back to Sarah and ask you, how do you, like you're saying, you get $50 for every dollar that you put in, and yet it's such a difficult, story to convince political leaders to go down this path. How do you convince the world to address TB?
I think I have a small role, honestly. I think in HIV, what we learned is that advocacy from people with HIV, from affected communities, demanding care for themselves and for their loved ones, was the most effective way to ensure disruptively demanding effective care, and research and resources was the most effective way to push the agenda forward. And so I consider my role one of from this school, talking about TB research, the opportunities for transformative intervention, but really the most important voices will be from the people who are directly affected, the communities affected.
Yeah.
Yeah, I mean, I think this panel is kind of a nice representation of contributions. We are missing some voices, like Sarah was saying, but you're just an extraordinary storyteller, and that obviously is so important to communicate this impact. That for some people, the $50 return on investment, those are going to be the magic words, and for others, it's going to be Shreya's story, and the fact that this young woman died because of a system that excluded her from getting the first new anti-TB drug in 50 years, and it was for like stupid bureaucratic reasons on a foundation of an unequal system and an extremely expensive drug, or a high-priced drug, I'm going to say, because it's not inherently expensive. But here, so we've got, you're an amazing storyteller, you're a basic scientist, I'm an epidemiologist, and also do some advocacy and work with activists, and I run clinical research projects, and we have a modeler here.
I run the numbers.
Right. So I think we try to reach all the audiences, and together with our friends who are TB survivors and also part of civil society that has allied themselves with TB survivors. We clearly haven't we haven't cracked this nut completely. We welcome others to join this quest.
Yeah. I feel like a lot of we talk about hope at this point, and there are TB patients who every time I talk to them, they say it's hopelessness is such a luxury that we can't be what that would mean for us to just sit down here and passively die.
That's right.
And a lot of these fights, like Fumeza and Nandita, who challenged the patent on bedaquiline, and so much inspiring leadership actually comes from survivor activists in my part of the world especially. I feel like we have some time to take questions that were submitted before by the members of our audience. We have a question from John, which I would, any of you can, I'm going to throw this question out there. How do we ensure that those who need it the most, patients in developing countries, also benefit from new technologies in TB? How do you ensure that?
I'm happy to take a shot at it. So I think it's exactly the same partnerships that we've been talking about. So partnerships with affected communities, partnerships with governments and policymakers. So we have the new treatments for drug-resistant TB we've been talking about. We have new treatments for drug-susceptible TB. We have the newer preventive therapy that we've been talking about. And so a group of service organizations and activists and researchers developed a campaign that we called the 146x24 campaign. And the 1 was referring to the preventive therapy for 1 month. The 4 was referring to the treatment for drug susceptibility, for drug-susceptible TB, and the 6, the treatment for drug-resistant TB. And it was really about trying to elevate the information so that everybody involved would know that these existed, would know that they were recommended by the World Health Organization, which is kind of the gold star for many, many countries, and the North Star for many countries, trying to understand how what the barriers were to communities actually getting access to them were all important parts of the campaign. And the campaign was also, the foundation of the campaign was invoking the right to science, that is part of the Universal Declaration of Human Rights, that everybody should have equal access to the fruits of scientific advancement, and helping people claim those rights and using entities like community-led monitoring to hold governments responsible for actually fulfilling those rights. It needs to be a multi-pronged package.
If I may, about like comparing this to the HIV movement, which was just so vocal and so disruptively demanding, how do you place the advocacy within TB in context of what we saw with the HIV?
I think we're still in a toddler stage of activism, I would say, in TB, and we've learned so much from the HIV activists. I mean, that's really where much of our activist experience comes, the organizing comes from, is the HIV community. It's been challenging, truthfully, because one of the big differences about the HIV epidemic at its start was that it affected wealthy people with access to power. And those people were terrified for their lives and the lives of their friends and their family members, and that was very motivating. And in TB, disproportionately, the people who are affected do not have those same open channels to the halls of power, and perhaps feel like they have more to lose also by challenging authority. So I think TB activism does rely more on people who may not be directly affected and kind of an allyship with those who are directly affected in order to make strides. But we have seen some improvements. You mentioned the secondary patent case in India that was allowed generic production of bedaquiline to go forward. There is a whole new generation of TB activists that have been nurtured by the YouTuber and young adult author John Green, who also contributed to longstanding activists' efforts to end the whole issue of secondary patents for bedaquiline, and also work together to have the price of one of the diagnostics dropped by about 20%. So it is reassuring. There are new movements. The online platforms are getting activated for this in ways that were not possible for HIV.
It is a very interesting space to watch as a journalist, because it's not how it was even 5 years ago.
Right.
The space. We are in the last 5 minutes of our discussion, so I have one closing question to all of you. If you had like one wish, whether it's a scientific breakthrough or policy, or all three of you get a magic wand, what would you do with the magic wand?
I mean, in TB we've been beset with okay enough interventions for a long time. So a vaccine that works.
To that.
Works at preventing and stopping progression, both.
Yeah. Oh yeah, that'll be good. Thank you.
And no anti-vaxxers at that.
I mean, if I get more wishes, I'll give you more. But yeah.
But that's how you get 2 in 1.
Yeah.
I think mine would be really foundational. I would wish for equity, because I really don't think that the global eradication of TB is possible without something approximating equity. I think we can make good progress, but equity would seal the deal.
Yeah.
And I would wish that TB patients be seen as individuals of importance, and individuals whose disease is allowed to be unique to them, that they're not sort of just numbers in the giant World Health
in the
ledger,
exactly.
where everybody's going to be treated the same way. The advances in cancer care, if you're allowed to see that person as an individual whom you're going to treat individually, have been enormous.
Yeah.
And I think that TB is poised to benefit from that. That TB is not all the same. Like the asymptomatic TB and active TB, that's not all the same. And if we allow that complexity, that we will do better in terms of controlling the epidemic, but that we have to be ambitious in our view, in our hopes for the control of the disease.
It makes me think, when you say if you allow for that complexity, is that a policy bottleneck, or is that a human?
Yes.
Yes, I think both. I think both. That the field has been resource limited for so long that the field has wanted everything to be simple. That they have imposed simplicity, and then if you deviate out of that, that deviation is stamped out. And so, understanding the complexity is going to be very important in terms of controlling the disease as we move forward.
Yeah. I'm going to give myself a magic wand too.
Oh, please.
If I had a magic wand, I would make it so that people had taxpayer-funded universal health care, which, Thank you for this thoughtful conversation. If you missed any part of this program, you can view it on demand on the YouTube channel of the Chan School of Public Health. Have a wonderful afternoon. Thank you for being here. Thank you for being here.
Thank you.
Thank you for being here.
Thank you.